Dr. Rudy, you can start anytime.
Good evening, everybody. Thank you for joining us in this migraine masterclass, which is in collaboration with the Association of Migraine Disorders and sponsored tonight by Pfizer. So tonight we're gonna speak about migraine, and we have two speakers that will speak a little bit about the migraine in pediatric and about the management of migraine. So my first speaker for tonight is Dr. Diana Dugan. Dr. Diana is a pediatric nurse practitioner and headache specialist with 17 years experience. Dr. Dugan completed her baccalaureate nursing degree at McNeese State University in 1998 and graduate pediatric nursing studies at Wright State University in 2002. She earned the Doctor of Nursing Practice in 2019 at Texas Women's University. Dr. Diana aims to educate children and adolescents about their neurological condition and offer treatment options, improve their quality of life. She strives to thoroughly address medical and behavioral factors that impact the health of pediatric patients who suffer chronic disabling neurological disorders and has been recognized as rewarded for excellent clinical care at Texas Children's Hospital. Dr. Diana is an active participant in state and national professional organizations where she has served on several committees, including past president of the Houston area chapter of the National Association of Pediatric Nurse Practitioners. Dr. Diana is motivated to contribute to nursing and medical science by teaching clinicians in training and designing clinical investigations inclusive of holistic interventions to help children and adolescents achieve their best health. Dr. Diana, the floor is yours.
Thank you for the invitation, and I'm honored to be speaking to you all. I hope that the information that we discussed today will help benefit you as clinicians, particularly being on the front lines of healthcare when seeing children and adolescents with complaints of headache. Next slide. Let's see, let me share my screen here. I have no financial disclosures, although some pharmacological treatments mentioned in this presentation are off-label and not approved by the United States Food and Drug Administration for use in the pediatric population. Next slide. So I'm not going to read through the learning objectives for the sake of time. However, I will mention some specific migraine-related symptoms that we see in the pediatric population that are a bit different as compared to adults. And taking those into account, individualizing a migraine management plan that can be utilized to help kids for both acute and preventive treatment. Next slide. So to start, we know that there are over 100 different headache types that are classified by the International Headache Society, and this link is included on this slide if you had an interest to peruse them. But in the sake of pediatrics, we're mostly going to focus on primary headache type and migraine. But when you first encounter a patient that has a new chief complaint of headache, we need to consider either primary or secondary headache types. Next slide. So this is a bit of an overwhelming slide, but this is really just a snapshot of some of the more common headache types that are seen, that are described in the International Headache Classification. So part one are primary headache types, including tension type headache, which are the most common type of headache that most individuals experience in their lifetime. And secondly, migraine, which is the most disabling headache type worldwide. There are, even in kids and adolescents, there are kids that suffer from chronic migraine or status migrainosus, which is a migraine lasting longer than 72 hours in duration. Highlighted on this slide, though, are cyclical vomiting syndrome, abdominal migraine, and other headache types that are specific to pediatrics. So even with cyclic vomiting syndrome and abdominal migraine, typically those patients, they can present very young and they don't have any complaint or behavior associated with headache. Instead, they have bouts of acute gastrointestinal disturbances. Typically, they're worked up thoroughly by gastrointestinal primary care colleagues before they come to us in neurology to help solidify our diagnosis. There's usually sometimes a hunch that they may have abdominal migraine, but these are all syndromes that may be associated with migraine, with the thought that as children, there's a lot of rapid growth. Specifically, we know there's the most rapid amount of growth in the brain from birth to 3 years of age. We have seen and diagnosed toddlers as young as 2 years of age or even younger with some of these episodic syndromes. And as they continue to grow, sometimes these episodic syndromes will evolve into more of a classic style migraine. Now, thinking also about the secondary headaches are part two. So if you have a headache that occurred directly as a result of an instigating either injury or illness, then they are considered secondary headaches. So, but what's really intriguing is you can certainly have 2 or 3 different headache types in the same child or individual at the same time. So you can have, for example, a child who had episodic migraines, but then they experience a concussion. And then now they have a secondary headache attributed to head or neck trauma. And then that secondary headache can in turn exacerbate the primary headache. So the point of this slide is just to kind of give you information that there are specific criteria out there per the International Headache Society. And it really is helpful for us so that we can arrive at the most accurate and comprehensive diagnosis. Next slide. So what is a migraine? We know it's an inherited neurologic disorder characterized by sensory, autonomic, vestibular, cognitive, and gastrointestinal symptoms. It's not just severe head pain. And I try to emphasize that there is a known genetic predisposition because there's a lot of families, especially when they have a younger child with migraines, who are understandably concerned about the prognosis and potential underlying pathology that may be harmful. And so we want to explain as much as can and set to families and set up expectations about what is a migraine. It is a chronic neurologic disorder, and our efforts are aimed to try to help reduce the frequency and severity of their migraine attacks over time. Next slide. So what we know about prevalence of migraines in general is that 1 billion individuals worldwide experience migraines. And of those, 1 in 5 are women. There's definitely more of a burden that's seen in women as compared to men. However, 1 in 11 children experience migraines. And what is known is that half of adults who experience migraines began to develop migraines in childhood. Next slide. With regard to incidence, what we've typically seen anecdotally and clinically is reflected in this graph from 2019, where we typically see the mean age of onset in migraine around 8 years of age for boys, although certainly it can be much younger, and then around 9 years of age for girls. What we also see is that typically the closer that girls approach puberty, the closer they get to puberty, then that's when we typically see the migraines begin. Next slide. And compared to other common pediatric disorders, migraine carries a heavy burden. I think this slide definitely opened my eyes to, as compared to ADHD and asthma and even ear infections, thinking about a pediatrician or any provider working in primary care that you're going to encounter the chief complaint of headache and migraine quite a bit, even in children. Next slide. And because of that, migraines, we know that how the frequency, the prevalence in kids, unfortunately, the consequences of migraine, that it does impact their school performance. And so with regard to attendance, because if they're just not able to attend school, if they need to arrive late or leave early, we see a large impact on school attendance because of migraine. And then also with school reported problems. And this is perhaps a bit vague, but to consider this when a child needs to ask the teacher to be excused to go to the school nurse because of the headache, or perhaps they just lay their head down. It's also hard for them sometimes to learn. Imagine having a headache, even if it's not severe, but a moderate headache, and trying to learn a new math equation or how to solve how to plug in a formula. You're not going to be, the kids aren't at 100%. And so there's struggles with their school performance related to the migraine. And then also, unfortunately, that may lead to the necessity for them to repeat a grade. Next slide. So pathophysiology of migraine, just in brief, we don't have a complete understanding of everything involved that's going on inside the brain during a migraine attack. But what we do know is that there is activation of the trigeminal nucleus caudalis, thalamus, hypothalamus, and cortex. And there's several neurotransmitters and neuropeptides, for example, calcitonin gene-related peptide, neurokinin 1, that are produced in the trigeminal ganglion. And this is known to play a role in the modulation of pain transmission and vascular tone. So data from studies that are recent support the impression that a pre-sensitized state exists in the peripheral nervous systems of individuals with migraine. So this explains why even when you're not in the middle of a migraine attack, even with kids, that they can still have light sensitivity and noise sensitivity or osmophobia. Next slide. And during the phases of a migraine attack, there is an anatomical correlation of what's going on during these phases of an attack. So with the prodrome or premonitory symptoms, this is a hypothalamic event. And initially, before the pain begins, a child can experience fatigue, yawning, mood changes, and food cravings. Not all children or individuals with migraines experience an aura, but if they were to experience an aura, then we would see that either before the onset of pain, or after the onset of the head pain. And with the aura specifically, this is a cortical event referred to as cortical spreading depression. So the cortex changes that are happening in the occipital lobe would result in a visual aura. In the parietal areas, sensory aura, and in temporal areas would result in a language symptom related to the aura. And with the headache phase, at the onset of the pain, this is when we have trigeminal nucleus caudalis to trigeminal ganglia activation, and then followed by, after the headache attack has resolved, there's still a postdrome. So, and this can last 24 to 48 hours, and this is the cortex and brainstem in recovery, where there's still some residual fatigue, cognitive changes, perhaps neck stiffness. Next slide. So pertaining to auras, just briefly mentioned in the last slide, prevalence of auras in children is estimated to occur between 15 to 30% of children with auras. And auras may last 5 to 60 minutes. And the reason that this is delineated from 5 to 60 minutes is that an aura, especially any kind of sensory change that lasts less than 5 minutes, that may raise clinical suspicion for another neurologic issue, such as seizure. But typically we see auras last from 5 to 60 minutes. And within that time frame, there can be a succession of auras, but this is a bit reassuring to us that this is fitting within the International Headache Classification. Also, aura may occur before or during the headache, as mentioned previously, but it can also occur without a headache. So you can have a aura without the headache whatsoever. But those kids we usually typically follow fairly closely over time. Of the auras, visual aura is the most common aura, but kids can also report, for example, paresthesias to their extremities, even involving perhaps a cheek, their tongue, speech, language, or even motor deficits. But with auras that are migraine related, we know that they're fully reversible. When the headache attack has resolved, so the aura should have resolved as well. With specific mention of blurred vision, there are some individuals who report blurred vision during a migraine attack, but without any other positive or negative features of a visual aura. Generalized blurred vision on its own is not necessarily considered or indicated as aura. Next slide. So what's the difference between a migraine and a tension type headache? Since we're looking at, these are the top two most commonly reported headaches in pediatrics. The big differences that I hope to help you draw your attention to with highlighted is migraines are moderate to severe in intensity, whereas tension type headaches are mild to moderate. As far as the location of the pain, according to the international classification as mentioned here, kids may report pain, even adults, unilateral or bilateral. But in my experience with kids, typically when you ask them to localize their pain, where does your head hurt the most? Usually the younger kids will point directly to the midline of their forehead or bitemporal areas. It's usually not until later on in adolescence or late teens to where maybe the pain kind of migrates and becomes more unilateral. Whereas with tension headaches, the headaches can be bilateral also. A lot of times kids will describe it as holocephalic. A migraine has a throbbing quality of the pain, but in kids, sometimes, especially if they're very young, or they're not able to verbalize the description of the characteristics of the pain, when we ask them, what does it feel like when your head hurts? Can you describe it? Sometimes they'll say, it feels like a hammer is pounding me in my head, which has been helpful for us. Thinking about young kids too, especially if kids are nonverbal, for example, with autism spectrum disorders, then we may have to infer from their behavior what their activity level was prior to, and then after the onset of the attack, what changed? Did they stop what they're doing? Did they develop facial pallor? Did they lie down? Did they vomit and fall asleep? So considering how long of a duration a migraine attack must be for kids to qualify as a migraine per the criteria, the attacks need to last at least 2 hours. But we also consider the amount of time if they were to stop their activity, lie down and fall asleep. Even while they're asleep, we don't assume that their migraine attack is resolved. We assume actually the opposite, they're probably sleeping through the pain. So we consider that when the child is asleep, that is included into the duration of the migraine attack. But one of the main symptoms involved with migraine that's a giveaway is nausea or vomiting. With tension type headache, absolutely no nausea or vomiting can be experienced by the child automatically. With the presence of nausea or vomiting, tension type headache is excluded per the criteria. And then for migraine, sensitivity to light and noise, whereas with tension type headache, the child cannot experience no more than one of photophobia or phonophobia. Next slide. There we go. Now with triggers, I mentioned before that I typically try to educate families that the cause of migraine, and it may be a bit simplistic to explain it this way, but I think it can really help them understand the concept. There's the genetic predisposition. It's intrinsic, but triggers exist inside and outside the body that can certainly serve as catalysts to set off and bring about an exacerbation of migraines. Stress is number one, either physical or behavioral. There's times of the school year where we see a lot more stress built up than others typically, usually as kids get ready towards the end of a term with final exams, projects due, in combination with any other extracurricular activities or athletics that they might be involved in. It just becomes a cumulative overload, so to speak, and the stressors can be a strong trigger. Also, inadequate sleep, prolonged or strenuous exercise for very competitive athletes, fasting, dehydration, all of these things listed. Last but not least, and this is not an exclusive list, there are a lot of dietary triggers out there. And it's sometimes not always easy to identify an obvious trigger. For example, I had one patient who told me that every time they ate pizza from a certain store, grocery store that their family bought it from, that pepperoni on that pizza triggered a migraine, but they could eat pepperoni pizza from a different restaurant and they were fine. So it's really rare for families to be able to identify the trigger that specific, but the take-home message is not everybody's triggers are the same, and moderation is key. And if you start to notice a pattern, then it perhaps may be a migraine trigger. For example, MSG, which are additives in a lot of the junk foods, also chocolate, aged vegetables or fruits, things of that nature. Next slide. And being that we are on the front lines, seeing patients in clinical settings, a lot of times with kids and their parents, there's a lot of heightened anxiety about, are we really sure that this is what it is? As clinicians, we try to reassure the families if we have ruled out that we're not dealing with another disorder, their neurologic exam is normal, and also the characteristics of the headache and the headache pattern are reassuring. This leads us to the next slide. So consider the presentation pattern. So reassuring patterns are acute recurrent. So there's, for example, a 9-year-old female who she experiences 4 to 5 migraine attacks per month. And in between her headaches, she's completely at 100% baseline. Her activity level is normal. She's thriving in school, but during the migraines, certainly they are affecting her. And then also chronic non-progressive, where there are kids, it's unfortunate, where they actually experience chronic daily unremitting headaches for an extended amount of time, months to years, but that specific headache intensity on an average daily level, and also their associated symptoms may fluctuate a bit, but it's pretty much remained stable. Those are reassuring patterns. Although we have strategies for both, they're not alarming. Whereas worrisome patterns are, as demonstrated on this slide, when you have acute thunderclap, a chronic progressive headache, where you have a drastic change and an escalation that raises concern, any kind of drastic change in pattern as well that warrants further evaluation. Next slide. We go to the next slide. Sorry about that. Great. So with regard to red flags specific to children, this is a mnemonic that some of you may have come across in the past. We call it Snoopy, with regard to what findings would cause us concern to really investigate for underlying pathology that would then result in a secondary headache. So any systemic symptoms, Secondary risk factors like immune deficiencies, cancers, in kids, diabetes type 1. If their sugars are not adequately controlled, that can certainly exacerbate and potentiate headaches. Neurologic signs that are abnormal, papilledema, onset of the headache, if it's sudden, occipital in location. There's a debate on this, specifically with regard to if the pain is only occipital, if it's isolated to the occipital area, especially in the pediatric population, we typically want to address the possibility of a cervicogenic headache, or was there a history of injury, because that location of the pain in and of itself isn't entirely associated with migraine. You can, like I said earlier, have a combination of 2 or 3 headache types, but we would really want to do more thorough evaluation. A pattern change, precipitants. So Valsalva or position change, specifically, is the headache at its worst first thing in the morning when their head is still on the pillow and they're open their eyes? Is that when the pain is intense? Or they can't tolerate coughing or bending over? We may have concern for increased intracranial hypertension. Also with a young age. So any child younger than 6 years of age that has a concerning fulminant onset of headache, then this would definitely raise your red flag. Next slide. So clinical pearls for the clinician: when you're faced with these red flags, you're seeing these patients and you're concerned, what is their disposition? What should you do? So for thunderclap headache, or the worst headache of their life, they've never had a headache this bad before, then we send them to the EC. Also, if it's intractable vomiting upon awakening, we send them to the emergency center. Any kind of abnormal neurologic finding, including fundoscopic exam, and then any concern specifically with regard to fever, when we're worried about a central nervous system infection, we send them directly to the emergency department for prompt evaluation. Yellow flags are, well, we're concerned, but we're comfortable that we may, with close follow-up, order an evaluation as an outpatient, specifically thinking about imaging or referrals to other providers, maybe ophthalmology. So a patient younger than 6 years of age, a new onset or new daily persistent headache, change in headache pattern. By the way, we saw, and we had been seeing quite a bit with even in adolescents with long COVID, where they had definitely what presented as what would have been a new daily persistent headache, although they had a temporal relation to acute COVID infection a few weeks prior to that. A side-locked headache, headache consistently waking a patient up from sleep, especially in the pediatric population, that is a concern. And then also positional headache or Valsalva induced. Next slide. So with regard to evaluation, there are diagnostics that we typically order to investigate what's going on, and specifically for any kind of anatomical abnormalities that may be a cause for a secondary headache. There are a variety of imaging options that are available, but that may depend on your location, what area you're in, if you're in a hospital-based clinic, or if you're in a rural area where there's not much available. So a brain MRI is preferred as first line, where that really is going to reveal more as far as looking at the tissues, white matter, gray matter, and structures of the midbrain. However, if there's a concern for an acute bleed, if there's been trauma, then a head CT, if that may be available first and much faster. But going back to the MRI, typically we order without contrast. And the reason is that magnets have, the technology of MRI has improved to the point to we typically don't necessarily need to give gadolinium containing compounds. There is a concern with gadolinium compounds, which is the contrast that's used with MRI, is that there are still some trace amounts that have been found in tissues years later after administration. So just out of an abundance of caution, we avoid using contrast unless there is a known lesion that we need to check for interval changes. Lumbar puncture, if there is a concern for intracranial hypertension or even low pressure, and also labs to evaluate for systemic illness and any other markers of inflammation, nutritional deficiencies, and metabolic screening. Next slide. So, and there are some resources available to help and that have given guidance to clinicians about trying to avoid unnecessary imaging exams. But there's the consensus is that if there is a normal neurologic exam and there's no atypical features and the headaches are consistent with migraines, typically neuroimaging is not recommended even in children unless there's some of those red or yellow flags or the Snoopy mnemonic that make you have a clinical concern. Next slide. So now on to migraine management. Next slide. Briefly, let me just kind of mention first and foremost, the foundation of our management plan really needs to involve making sure that kids are adequately hydrated. And this is just what we typically use to calculate maintenance fluid requirements. The kids are getting nutrition that's good. The best way to get the nutrition is through the whole foods that we eat with dark green leafy vegetables and fruits, legumes. However, sometimes kids are picky, and so we really need to sit down and kind of sort through what is their typical diet on a daily basis consisting of. Gives us opportunities for counseling and encouragement. Also, routine exercise doesn't necessarily have to be strenuous exercise, but exercise. Walking is great. If that's baby step, then that's one thing at a time that we can do to encourage them to exercise, maintaining a regular sleep cycle, and then managing stress. Next slide. So with acute care, looking at what do we have to offer children that have breakthrough migraine attacks. I like this slide. This is actually borrowed from the American Headache Society, where looking at there's kind of a small fire, medium fire, big fire. So for a milder to moderate headache, we can start with trying an NSAID and then making sure, looking at, are there any triggers that are going on? Do they need to eat? Do they need to hydrate? Do they need to rest? Perhaps those interventions alone may stop the migraine from progressing. Whereas if the migraine is already moderate to severe, we may consider giving them a triptan either alone or in combination with an NSAID. And then when the migraines are at their worst, specifically if they're involved in associated with nausea and vomiting, then we can also, in addition to triptan and NSAIDs, consider giving them a dopamine antagonist. Next slide. So here is a list, American Headache Society guidelines and AAN, looking at the different triptans, NSAID. Now you can also have provider preference, but these actually do have FDA approval for children and adolescents younger than 18 years of age. Specifically, looking at zolmitriptan, nasal spray, has an indication for 6 years and older, and rizatriptan, the dispersible tablet, also has indication for 6 years or older. The remainder of the triptans are approved for 12 years of age and older. As providers, if we can maybe perhaps switch triptans and consider others off-label. And then these are the most common dopamine antagonists that we have available in the United States that we use to try to abort the severe migraine attack, especially if they are associated with vomiting or they're persistent despite administration with an NSAID with the triptan. Next slide. The next slide is really just more of a comprehensive list of there are triptans that we do sometimes use, again, off-label. The benefit of frovatriptan and naratriptan is that they do have longer half-lives. So in instances where adolescents may have menstrual-related migraines or migraines that tend to just persist for days, those may be more beneficial to try. Again, that's up to the discretion of the provider and disclosure to the family. Next slide. Now, with regard to triptans, as I briefly mentioned, they're available nasal spray, dispersible tablet, or tablets that are swallowed whole. But typically when you're prescribing these, there's a rule of 2. No matter what the formulation, you can take a second dose if needed after the first dose, but there needs to be a 2-hour time frame of between the first and the second dose. And that's pretty much true. That's true of all triptans. And typically no more than 2 doses in a 24-hour time frame. And we ideally encourage patients and families not to administer or give or take triptans any more than twice per week to avoid medication overuse or rebound headache. So, and just also a little note, being that we see a lot of kids that have comorbid anxiety and depression, and they may also be taking an SSRI or SNRI per psychiatry to manage those conditions. Oftentimes when we prescribe triptans, there is a drug-drug interaction, kind of a pop-up box that may present to us to say, oh, there's a risk of serotonin syndrome or serotonin toxicity. But the American Headache Society has issued a position statement that says there's really not enough available evidence to support the limited use of triptans, being that triptans are administered on an as-needed basis. Triptans are not prescribed to be taken daily. So being that it is used ideally in a sparing type of acute treatment, we typically will prescribe triptans even if the child is taking an SSRI or SNRI. Common side effects to warn children of is, with regard to triptans, particularly sumatriptan, is they can have tightness of the face, neck, and chest. They can feel hot. It can be really, for some, intolerable, and for others, it's not bothersome at all. So we really ask the kids, how do you feel? Does it help you? Do the benefits outweigh the side effects? And so that's what we take into consideration when we revisit and see them for follow-up. Contraindications to triptans is heart disease, cerebrovascular disease, rare migraine subtypes such as hemiplegic migraine or migraine with brainstem aura, and uncontrolled hypertension. Next slide. So we typically formulate a migraine action plan or migraine management plan for kids to have at school. It's helpful for the school nurses to have this so they can follow along, similar to an asthma action plan. So that we have a step 1, again, with that stratified care, step 2, and then step 3 if the migraine persists despite those initial interventions. And this is really helpful to have on file with the school, and hopefully it can help ameliorate some conflict that can happen with regard to the missed amount of school that they have and needing to miss class to treat the migraine itself. Next slide. So a few pearls for quick treatment. So if one triptan is tried and it's not effective, we typically will switch and try another triptan. Once we've tried 3 separate triptans, typically it's what are the chances that a 4th triptan may be effective? It's rather slim. So again, kind of at the discretion of maybe we need to think about a different combination of approach, thinking about trying a different NSAID. And then if the migraines are quite chronic, especially if they're near daily, a lot of times triptans just they are not effective and they won't work well. It's not to say that they may not work later on, but until we have a good preventive plan in place, the acute plan may not be near as effective. And then please refer to a headache specialist if you feel that you've exhausted all options, and let us help see if we can get a different plan in place to get their migraines better controlled better effectively aborted. Next slide. So when do we prescribe preventive therapy? When there's frequent days of headache, it interferes with school activities, you may have a patient-parent preference to do so, and especially if they're too frequently taking acute medications. Next slide. So nutraceuticals. I consider nutraceuticals as first line, but then it also depends on the fulminant nature of the headaches themselves. But a lot of families are willing to try nutraceuticals initially. Riboflavin has fairly good evidence to be of help. Magnesium is thought to have anti-inflammatory properties to it. Coenzyme Q10 also can be helpful. Melatonin, there's a little bit of conflicting evidence as far as how effective it is at managing chronic migraine. However, it may be helpful for kids that have difficulty falling asleep, especially on school nights. And just of note, Petasites or butterbur root is no longer currently recommended for use as a preventive, although there was some supporting evidence that it could be helpful, but there is a naturally occurring element in the root that are phenylalkaloids that can cause liver toxicity. And to be cautious, we don't want to cause that kind of toxicity or liver damage in kids. So we've avoided it. It's really difficult to detect how much of those PAs are in the root itself. There may be some manufacturers who can ensure that, but until we have more reassurance, we have abandoned recommending it for use in kids. Next slide. With pharmaceuticals, there's topiramate in the United States is the only preventive medicine that has indication for use in children 12 years and older. Whereas amitriptyline, propranolol, valproate, and cyproheptadine have been used for years first line as pharmaceutical agents to help manage migraines on a preventive basis. Really, we have to look at the other possible comorbid health factors that are going on with the child and make the best judgment that we can and discuss possible side effects and goals for treatment with the family regarding each medication. Next slide. And also to mention other strategies that can be very helpful, especially in tandem with pharmaceutical and nutraceutical treatments, are the biobehavioral approaches, where biofeedback, cognitive behavioral therapy, clinical hypnosis, physical therapy, and acupuncture can be extremely helpful, and in some cases are more helpful for the children as compared to several preventive medications that they've tried. So these strategies definitely need to be brought to the forefront of consideration when kids start to develop more frequent migraines or chronic migraines. Next slide. But returning back to the notion of the first line pharmaceutical approaches that are used for prevention, there was a study that was conducted several years ago that looked at head-to-head the benefits, the efficacy of topiramate versus amitriptyline versus placebo in children over 24 weeks that had frequent to chronic migraines, and the findings were a bit surprising because neither topiramate or amitriptyline had demonstrated any improvement over placebo. So what this tells us is that there's really no one slam dunk surefire treatment approach as far as pharmaceuticals that's going to be guaranteed to be efficacious. What we have to do is consider each child on an individual basis, looking at their holistic health, and then considering all other possible treatment strategies that may be beneficial to them. And if we do select a pharmaceutical option, that we consider the side effects and how that may impact their health as well. Next slide. So some tips: set appropriate expectations. I wish we could bold highlight this and make this 60 font. Families need to understand that even though we are starting a preventive treatment plan, they're still going to have breakthrough migraines. There's no cure that just because they're going to start this medicine, that doesn't ensure that they're never going to have breakthrough migraine attacks. And so the expectations need to be clear that we're using this medicine to try to help slow down the progression of, or reduce the frequency and intensity of, to improve quality of life. There are naturally always super responders. There are some kids, even adults, who try preventive and it's like they've got a completely different life and they don't remember the last time they had a breakthrough migraine. But that's typically not the case. So we really want to set expectations. We also want to be forthcoming about possible side effects. And by trying to mitigate those from being intolerable, we titrate slowly. And then the goal is eventually to, if we can get the migraine frequency stabilized, eventually over time try to wean off the medication. This isn't a medicine that we intend for them to take forever or for the rest of their lives. Next slide. So if they are referred to headache specialists, there's other treatment options that we can consider, CGRP antagonists, Botox injections per chronic migraine protocol, nerve blocks. And then what's really promising is neuromodulation devices, of how these have come available and have authorization for use in the United States for kids 12 years and older. Next slide. So in summary, we want to make an accurate diagnosis, rule out secondary headache types, provide acute treatment with a management plan for school, also some preventive strategies, and then also consider behavioral, nutraceutical, and other medical managements in combination to reduce their disability. Next slide. Thank you, and I'm happy to take any questions. I apologize for going over time.
Thank you, Dr. Diana, to this very important and informative presentation. I have a couple of questions from our audience asking you. The first question is, usually what's the prevalence of migraine in kids? It means, maybe he means by, if, for example, how many kids, or what's the percentage of migrainous kids that you're seeing in your daily life?
Well, we know that the prevalence that most recently reported by World Health Organization is every 1 in 11 children. So that's quite a bit. And we see, as referring back to the one slide that looked at prevalence in males versus females, we certainly see an increased prevalence through the adolescent age with females. So now certainly males also suffer with migraine and even chronic migraine, but as we get further through adolescence and adulthood, then that's we see more of a separation between the prevalence of female to male being 3 to 1.
Thank you. So my next question, Dr. Diane, what food can prevent migraine in kids?
So thinking about magnesium rich and antioxidant rich, like coenzyme Q10 and the riboflavin, it's the dark green leafy vegetables, kale, broccoli, also vegetables and fruits of various colors. So there is a certain benefit to getting a lot of green vegetables introduced into their diet. But understandably, there's a lot of kids who don't like vegetables. And it can also be a textural issue. They don't like the way it feels in their mouth, the taste. So those are the situations where we still encourage them to eat the food, but then we may need to supplement with a nutraceutical to ensure that they've got enough nutrition to try to help naturally fight off the migraines.
Excellent. So, and I have a question also about the milk and the importance of milk in migraine patients.
So with regard to, I see the question regarding Aimovig and CGRP inhibitors, yes. Now, in the United States, we do not yet have, there's no FDA authorization for adolescents or children younger than age 18. However, there are a few that are in phase 3 studies to get that indication. With that being said, we make decisions as providers to sometimes prescribe off-label, which I have, and I know a lot of my pediatric headache colleagues have. And we still haven't found, although this is anecdotal, a predictor as to which patients will respond. But I can tell you that I have had patients respond remarkably well to any of the CGRP inhibitors, including Aimovig or even Emgality or Jovi, that they even had previously trialed Botox and they had no benefit. Whereas when they tried the CGRP antagonist, it was significantly better.
I have a question from our audience asking you, some doctors prescribe candesartan. How does this drug affect in preventing migraine?
That's a really good question. In fact, it's not on the slide that I showed you because it's considered third line, although we could argue it may be considered first line. I believe it's a calcium channel blocker. And there are some abstracts and reports that have been published and presented at American Headache Society that show that for some individuals, it's shown to be beneficial to reduce their daily migraine intensity. Typically, these are kids to where we've already tried a number of the first line preventives, even perhaps Botox. And so candesartan is thought to be a potentially helpful tool. Again, it's off-label use in the United States, but from that mechanism, similar to, for example, verapamil, or there's other medicines that are considered second or third line that may be beneficial. Unfortunately, it's a lot of trial and error.
Dr. Diane, I have also an interesting question, challenging question. Is migraine hereditary? And if yes, how can it be minimized in future offsprings?
I'm actually really thankful for this question because I found a recent article in Nature Genetics published last year where a genome-wide analysis of over 100,000 migraineurs and over 77,000 controls, they identified 123 risk loci to where you can carry the migraine trait. So yes, absolutely, it's hereditary. And that may also explain why not everybody's migraine is alike. Not everybody has all the same features, and not everybody has the onset at the same time. There's so many types. But then there's also what do patients respond to? Again, we go back to, unfortunately, it is a lot of let's try this and see if this is going to work. Well, if not, we're going to try this. So it is definitely hereditary. And as we continue to gain more data worldwide with the Mendelian database, I anticipate we're going to find even more loci.
Thank you for your answer. And Dr. Diane, how important headache education for the whole family in the management of pediatric headache? Ms. Vera is asking you from our audience.
That's a really good question too. So, and it is important that the entire family has an understanding and a commitment to, it's not going to work. It's going to be more challenging for a child with migraine to be told that you really need to limit the amount of caffeine and chocolate and junk food and go to bed at a certain time and keep a regular sleep routine and maintain a healthy lifestyle that's recommended if other family members aren't participating also. So from a family standpoint, it is really important to educate them all as to the importance of that. Otherwise, if the lifestyle habits are not practiced, no medicine or treatment strategy that we have is going to have near the chance to be as effective as it could be.
One of our audience is asking you, how do you diagnose and manage abdominal migraine, which is seen in children, and any specific investigations to be done?
This is typically, these patients are typically referred to us, meaning pediatric neurology, and then our headache clinic from our gastrointestinal colleagues who have usually done workups as far as screening for celiac disease and other food sensitivities. Sometimes they've also had endoscopic exams, and they can't find anything abnormal. But then also there is somewhat of a temporal pattern at times in a presentation to where they'll refer to us and they say, could this be abdominal migraines? And in such a case, depending on the frequency of those attacks and how debilitating they are, if let's say if they're episodic, occurring less than 6 or 8 times a month, what we can do is try a triptan. Try a triptan. If it aborts the abdominal migraine, which typically per the International Headache classification involves no headache at all, but if the triptan works, then that's not just therapeutic, it can help us in being diagnostic.
Dr. Diane, also an interesting question. Can child migraine totally healed as they grow or become adolescent?
I love this question too. So now with healthy lifestyles, and research does show that if we can gain better control and reduce the severity and chronicity of the pain in childhood or adolescence, then the better the chance these kids have through their adulthood not to suffer from chronic migraine. With that being said, no one's life is perfect. Stressors, stressful events, illnesses, they happen. So there are some people who they haven't had a migraine maybe for a couple of years, but then a stressful incident occurs and then another migraine may come out. So going back to the pathophysiology and the genetic predisposition, once our brain experiences its first migraine attack in our lifetime, unfortunately, our brain remembers. Think limbic system and pain memory and all of these structures involved. The brain will know to go back and have another migraine attack. We can never go back in time to being that migraine pain naive. So hopefully there will be a longer amount of time where they have remission of their headaches in between attacks, but there's no guarantee that they will never experience another headache attack again as of this point in time.
And my last question for you for tonight, any benefit of chocolate in migraine?
You know, I am not aware of any studies that have looked at that question in particular. However, there are some that feel that caffeine can really help abort the severity their migraine attack, and that's a component in Excedrin migraine. There is caffeine, especially a higher caffeine content in dark chocolate. So I think that's a possibility, but I'm not aware of any literature that supports that. If any of my colleagues do, I'd appreciate you letting me know.
I can add also to this question. By the way, I have a lot of patients complaining of dark chocolate can trigger for them migraine. So it's the opposite even, but my patients mainly are adults, so I don't have experience in maybe kids and their chocolate. So, so thank you so much, Dr. Diane, for this excellent presentation. I'm gonna tell you that the audience, we are more than 1,400 person watching your session and the next, inshallah, session of Dr. Halprasan. So thank you so much for your presentation.
It's my pleasure. Thank you.
So I'm gonna move to our second speaker for tonight, our consultant neurologist, Dr. Halprasan. Dr. Halprasan is a consultant neurologist at Burjeel Hospital, Abu Dhabi. He has 12 years of experience in field of neurology. He's expert in headache and multiple sclerosis. He obtained multiple sclerosis certified specialist from Consortium of Multiple Sclerosis Centers in US. Dr. Halprasan worked for many years as consultant neurologist, and now since 6 years, he's in Abu Dhabi in Burjeel Hospital, and working as consultant neurologist. Dr. Halpresent has a special interest in the management of headache, multiple sclerosis. He has been involved in several clinical trials and has received numerous awards and recognitions for his work. He is committed to providing the best quality of care to his patient. He's a member of the American Academy of Neurology and the Indian Academy of Neurology. Dr. Halpresent, the floor is yours.
Thank you so much for this opportunity from the organizers and Pfizer and American Migraine Association. I hope my slides have been shared.
Yes, we're seeing your slides, Dr. Halpresent.
Okay, thank you so much. So, disclosure, speaker honorarium from the Pfizer and no other commercial vested interest. My talk today will be based on, these are the outline of my talk, and introduction to the topic and the case-based scenario, evidence for using oral Ramgepant in acute and preventive treatment of migraine, and we'll have a question and answer sessions. I'd like to thank the previous speaker, Diana, for giving an overall look over the pathophysiology, definition, incidence of migraine. And there is not much difference in the pathophysiology and the incidence compared to the adult and the pediatrics. But I like to highlight few things. Couple of slides might be overlap. The migraine is a complex neurological disorder characterized by recurrent disabling headaches. Migraine affects more than 10% of global population and 2 to 3 times more common in women than men. Despite of increase in diagnosis and treatment rate over the past decades, migraine remains an untreated illness. Migraine may have evolving frequency over time, transforming from episodic to chronic. It comprises a spectrum of headache-related disability where increasing frequency of attack associated with increasing disability. Migraine is associated with substantial personal, family, and economic burden, which worsens with increased frequency of attacks. The criteria of migraine has already been established and spoken by previous speaker. The migraine can be classified into an episodic migraine and a chronic migraine. The definition of migraine is during the lifetime, if the patient has more than 5 episodes of migraine headache attack, which is lasting for 4 to 72 hours, which has a criteria, which is the first criteria is the patient should have more than 2 of the following character of the headache: unilateral, pulsating, moderate to severe intensity, aggravated by or causing avoidance of routine physical activity. If there is no aura, the more than one of the following should be there: photophobia or phonophobia, nausea or vomiting. The episodic migraine headaches are those headaches where the headache frequency is less than 15 per month, and the chronic migraine headaches where the headache frequency is more than 15. In that, you can have more than or equal to 8 migraine headaches, and remaining headache could be a tension type headache. As previous speaker already has told, migraine is a disorder of neuronal excitability. Means the migrainer's brain and a normal brain, there is a difference. There is a threshold for the pain, or a trigeminal system is reset in patients with migraine. So, for example, there is an odor or a sound. Normal people who don't have migraine will not get trigger of the migraine or a headache. However, the patient who has migraine will get triggered by the odor. One of the easy explanation, which is established now is a hyperexcitability of the trigeminal vascular system. Whenever there is an excitability of a trigeminal vascular system, there is a first order neuron, which is coming from the brainstem to the trigeminal ganglion. Then the second order neuron, which is from the brainstem to the vascular system of the brain, like dural arteries. Then the third order neuron, which will spread across the brain, and mainly the thalamus which is involved. When there is a neuronal excitability happens, there will be a few nociceptive sensitization, which triggers vasodilatation, neuropeptide release, and inflammation. CGRP, calcitonin gene-related peptide, in migraine is a very important discovery which happened in 1982. It has changed the management of migraine since last 4 to 5 years. As previous speakers spoke, in adolescent and children, the treatment as usual traditional medication, which are beta blockers, anti-epileptic, antihypertensive medication. However, in adult, there is a drastic change in the treatment because of the discovery of this peptide. They found out patients who has migraine or when there is a migraine attack, this neuropeptide called CGRP is elevated in their blood serum. It is also present in the saliva. They also found this level of CGRP is increased interictally in patients with chronic migraine. When you inject this CGRP into a normal person, there is a possibility of a normal person getting a migraine attack. So this was a research which was done, and they found out CGRP induces migraine. It is where previously we used to tell migraine is only genetic reason. Of course, it is an important cause, but we know the pathophysiology. We know one of the neurochemical which is causing migraine trigger or a migraine attack. Other medication, other neuropeptides which are on research is vasoactive peptide and PCAP. There are a lot of medications, there are trials going on. So now we know this is, if you target the CGRP, there is a very good chance that we can reduce the frequency of the headache and attack of the headaches. CGRP is a molecule which is released from the trigeminal end and through the vesicles, which is released and which actually binds to the trigeminal nerve and also to the vascular endothelium. When a CGRP is released, when it binds, it causes vasodilatation, which is the reason of migraine headache. It also causes inflammation and sensitization of the trigeminal vascular bundle. If you block a CGRP ligand or a CGRP receptor through a medication, which are antibodies, or a anti-CGRP receptor antagonist, the CGRP will not cause vasodilatation and patient will not have a migraine attack. One important thing about this CGRP medication antagonist or an monoclonal antibody is it doesn't cause vasoconstriction like triptans. Currently, we have a ligand antibody, that is anti-CGRP antibody, which are available in the market, eptinezumab, framinezumab, and galcanezumab. The medication which are against the receptor called CGRP receptor antagonist, we have monoclonal antibody, which are enurumab, we have a GPANs. We remember there are GPANs which are initially discovered and which was trialed and it was stopped because of a liver toxicity. And we have a newer medication which has no liver toxicity. Those are all rimgepant and ubrelvant. The newer medication which is in the trial in the discovery in migraine is anti-PCAP38 antibodies. Still, it is under phase 2 trial. I like to share few of my cases and then we will discuss regarding the trials. 23-year-old lady, she's newly married, presented with history of hemicranial headache for 2 years. 2 to 3 episodes of headache per month, worsening for the last 3 months with increase in the frequency and severity. Migraine features were present, there was no aura. Her pain scale is 8 out of 10 and migraine disability assessment score was 20, which indicates a severe migraine. She is planning to start her family in coming months. She's already taken paracetamol with caffeine and zolmitriptan whenever necessary without much benefit. She has done an MRI of the brain, which was normal. So here is a lady who had a migraine and she has used medication, which are paracetamol and zolmitriptan for nearly 2 to 3 months and there was no benefit. So diagnosis is episodic migraine headache without aura, we advise her to start medication called Ramgepant, which is a new medication against anti-CGRP receptor medication. And we told her to use contraception while on medication, to stop medication 5 days before planning for conception. She did very well whenever she used this medication, and she used nearly for 5 months, and she stopped the medication as she was planning to start her family. So how to treat these type of migraine patients? Usually when a patient has diagnosed to have a migraine, we usually divide the migraine patient into an, as previous speaker told, in low intensity, moderate intensity, and severe intensity. We don't know which patient will respond to which type of medication. So we always try the patient with a first-line medication, which is non-steroidal anti-inflammatory. If patient is having nausea and vomiting, we usually give antiemetic. When we use this medication, at least 3 consecutive attacks, if the patient does not respond, we actually shift the patient to triptans. Whichever the triptan you use, again 3 attacks, not becoming better, we can use an alternative triptan, or we can shift to patient to a newer medication called ditans or gepants. So in our patients, the patient used an NSAID and paracetamol, and then triptans, then the patient shifted to a gepants, that is Ramgepant. So this is the way we use steeped care approach for migraine, acute migraine management. What is the goal from an American Headache Society of medication which are used in acute migraine headache? The medication should have a rapid and consistent freedom from pain and associated symptom without recurrence, restore the ability to function, minimal need for repeated dosing or rescue medication, reduction in healthcare resources, and minimal or no adverse effects. All people with migraine should be offered a trial of acute treatment. Blocking a CGRP receptor will reduce the pain and symptoms during migraine attack by inhibiting vasodilatation without active vasoconstriction, inhibiting neurogenic inflammation, inhibiting exaggerated pain signaling. A selective binding of CGRP receptor antagonist treatment in migraine without vasoconstrictive effect of triptans. So one of the important data or information we are very happy to share, these CGRP molecules, the medication which we are using does not cause addiction and does not cause medication overuse headache. What is the evidence for the medication to use? This is the data which is published in Lancet in 2019. The study was efficacy and safety and tolerability of Ramgepant orally disintegrated tablet for acute treatment of migraine. Ramgepant is a small molecule calcitonin gene-related peptide receptor antagonist, has shown efficacy in an acute treatment of migraine by using a standard tablet formulation. The study method was adult aged 18 or older with history of migraine for last 1 year were recruited in 69 study centers in USA. The participants were assigned to receive Ramgepant 75 mg orally or a placebo and instructed to treat single migraine attack, which is moderate or severe intensity. The primary endpoints were freedom from pain, that means patient has no pain after taking medicine, and freedom from most bothersome symptoms at 2 hours post-dose, that is photophobia, phonophobia, nausea, and vomiting. The results were very positive, where there is 21% of the patient at 2 hours had no headache. In placebo, we had around 11%. The p-value was significant. When you see a free from most bothersome symptom, 35% had no symptoms compared to a 27% in placebo. The pain relief started as early as 15 minutes after taking medication, and it was lasting for about 48 hours. The pain relief started in 59% of patients with medication and with Ramgepant, and 43% with placebo. Of those patients who achieved pain relief at 2 hours, 71% continue to experience sustained pain relief through 48 hours. So there is 86% of patients with Ramgepant, which is also called Neurotech, did not require rescue medication in the first 24 hours versus 71% with placebo. As I already mentioned, the pain relief returned to normal and pain freedom started as early as 15 minutes and continued till 48 hours. Sustained response from 2 to 48 hours, 63% of patients taking Ramgepant who experienced freedom from pain at 2 hours maintained it through 48 hours. When they compare medication with triptan naive patient, current triptan use, triptan failure, and 2 triptan failure, there is significant improvement with Ramgepant compared to the placebo in all the groups. There are new phase 4 study which is also going on in those patients where the migraine treatment patients are not suitable for triptans, where they had a cardiovascular risk factors. Ramgepant and the triptans, what are the difference? The Ramgepant is an early action at 60 to 90 minutes, ability to function normally after taking medication, pain relief and freedom from most bothersome symptoms. 2 hours, it starts working. It can sustain effect from 2 to 24 hours, in some patients 2 to 48 hours. The most common adverse effect in this medication was nausea. The long-term safety was maintained through 52 weeks. In triptans, 42% of the patients require the second dose after 2 hours. 67 to 82% of triptan user experience migraine recurrence within 24 hours. 43% of the patients have treatment emergent adverse effect like nausea, fatigue, rapid heart rate, choking sensation, chest pain within first 24 hours. Triptan, as we know, it is contraindicated in patients with cardiovascular conditions. Switching to different triptan provides a pain relief at 2 hours in another 25 to 50% of patients. When I say that there is newer treatment, there are newer treatment available other than triptans are called Gepants and Ditans. We have 2 Gepants which are available in the market called Rimgepant and Ubrelvant. And we have a Ditans which are Lasmiditan. All are new medication and it has its own benefit and it has its own disadvantages. Rimgepant is a medication which is early action at 15 minutes compared to an Ubrelvant is noted at 1 hour. And Lasmiditan, the pain relief starts at 30 minutes with a higher doses. The benefit is sustained in Rimgepant for up to 48 hours compared to other medication. Ubrelvant is 24 hours and Lasmiditan is 48 hours. The overall medications, when we compare to each other, there is difference in the half-life. That means if you take a Rimgepant, one medication, one tablet works for 24 hours to 48 hours. But if you take a Ubrelvant, you have to take at least 2 tablets in 1 day for good pain relief. The side effect, which are most commonly seen in Rimgepant and Ubrelvant, is nausea, abdominal pain, and dyspepsia. In Lasmiditan, the problem was more of dizziness, fatigue, and sedation. So there is a caution where patient after taking Lasmiditan should not drive. So there is a comparison study. If the patient is having a migraine attack, consider 7 migraine attacks. Patient will take 10 tablets of Ubrelvant and 5.99 migraines. They'll take 8 tablets of Lasmiditan and 8 tablets for 8 migraine. Why it is important? These medications are costlier, and if the patient takes less medication, the less the cost to the patient. The fewer pills are needed with Rimgepant. Let us move to a second case, which is a 28-year-old male presented with a right-sided hemicranial headache for 10 years. He used to have 8 episodes of headache per month, lasting for 1 to 3 days, associated with migraine features and visual aura. There is a strong family history with mother having a migraine attacks. The migraine disability assessment score was 25. The pain score was 8 out of 10. The brain MRI was done already, it was normal. He has been on propranolol for prevention of his migraine attack and topiramate for 6 months each, with reduction in the headache by up to 50%. However, he could not tolerate the side effect. After taking propranolol, he had sedation and he was started to put on weight. Then he shifted to topiramate. Later on, after taking the medication, he started having speech issues in the form of memory disturbance, not able to find few words, and sedation effect. So he was not able to continue, but he started taking a lot of triptans, and unfortunately with triptan, his headache was not improving. The diagnosis was episodic migraine headache with and without aura. He was given an option of injectable monoclonal antibody versus an oral CGRP antagonist. He chose oral medication because he was scared of injections and he wanted to continue with oral medication. So we started tablet rimgepant, 75 milligram every other day. Headache frequency was reduced to 2 per month from 8 per month, and he used to have a very good response with sumatriptan. He's on the medication for nearly 6 months now, and he's doing very well. There is no side effects other than mild nausea in the initial 2-3 weeks. What evidence we have to start these medications? As a classical preventive treatment for migraine, as my previous speaker actually told, that we need to start with first line medication, second line medication, and third line medication. We should start slow medication, gradually we should increase, and we should have the high expectation with medication should not be there with the patient. We should tell them that it will take time. So this is the same words we used to tell our patient, adult patient, 5 years back. Now there is revolution changed in treatment of migraine because we have a specific medication. I still remember now also when I say you have migraine headache and I'm going to give you a medication called propranolol, which is a beta blocker. Patient used to come and ask me after prescribing or during the process, what type of medicine is it? I will tell them that this is an antihypertensive medicine. They'll ask me, I don't have hypertension. Why are you giving this medication? So I have to explain that this medicine is an antihypertensive, but it is used also in migraine. We have an evidence and studies. Next, I start on topiramide for one more patient. I say that it is an anti-epileptic drug, but we use also in migraine. So it is very difficult for us to tell the patient. Usually they'll go back, read about the side effect, come and ask, I am having a migraine, but you're giving anti-seizure medicine. For that matter, amitriptyline, which we use very frequently, it is an antidepressant. And why are you using for my headache? So these are the questions asked, but still we do use these medications now, but we always mention them. The reason for using is there are studies and evidences which helps us. The first line medication is beta blockers. Topiramide is an anti-epileptic medication and candacertran. The second line medication, if the first line medication fails, is flunarizine, amitriptyline, and sodium valproate. Especially sodium valproate we don't use unless otherwise patient is a male and resistant to previous medication. We don't use in women of childbearing age because of the teratogenicity. The third line of medication is botulinum toxin or a CGRP monoclonal antibodies and an oral CGRP antagonist. This is what which we are using from last 4 to 5 years. So what happened is there is a new recommendation which says that CGRP monoclonal antibodies can be used as a first-line medication in patients with migraine headache. Why? Because of the recommendation from European Headache Federation guidelines on use of monoclonal antibodies targeting a calcitonin gene-related peptide pathway for migraine prevention, which is a 2022 update. In individual with episodic migraine headache, the guideline recommends use of eptinezumab, enirimab, framinizumab, and galcanezumab as a preventive treatment. In individual with chronic migraine, we recommend eptinezumab, enirimab, framinizumab, and galcanezumab as a preventive treatment. So these recommendations are present, and there is individual with episodic and chronic migraine, we recommend enirimab over topiramide as a preventive treatment because of better tolerability. So this is a recommendation has changed where monoclonal antibodies can be used as a first-line treatment for patients with episodic migraine headache or a chronic migraine headache. What are the challenges which we had passed? The delayed efficacy. A trial of 2 to 6 months, including various titration period. This is I'm talking about the previous medication which we were using. So these are the unmet challenges. So we used to trial for 2 to 6 months, including various titration period, is often required before the benefit of the oral preventive treatment can be fully realized. The poor tolerability because of the side effect, as I told you, weight gain, fatigability, depression, and cognitive issues. Majority of the patient taking oral preventive treatment discontinued in 6 months of initiation of medication. What is the evidence for the newer drug, oral Ramjepan, for preventive treatment of migraine is the trial which has come out in Lancet 2021, which the study was done in an adult aged 18 and older for migraine of at least 1 year of duration. The first 4 weeks was an observation period where patients were given oral Ramjepan and matched with the placebo. They found out how many headaches they have. They found an average and they started giving medication in 2 different double-blind treatment phases, where patient was given medication every other day, 75 milligram, up to 9 to 12 weeks. The study was done at week 9 to 12, that is the 3rd month. They found out that there is a reduction of monthly migraine headache by 4.3-day reduction from the baseline compared to the placebo, which was 3.5 days. That was a primary endpoint, which was statistically significant. However, the medication, which is Ramjepan, was started showing the benefit in first week. There is a 30% reduction in weekly migraine days in the first week of treatment. So the mechanism of action and the onset of action was very early, as early as first week. As we know that this medicine is also used for acute treatment and also for preventive treatment. There is a study which is not a head-to-head trial to find out the efficacy between the monoclonal antibodies and Ramjepan oral medication. This is a network meta-analysis which shows there is no significant difference between monoclonal antibody, which are injectable, and an oral medication in patient with episodic migraine headache and chronic migraine headache. However, Ramjepan was used only in episodic migraine headache. What are the additional benefit of using Ramjepan compared to the monoclonal antibody? The most important benefit is short half-life. If a patient takes the medication, oral medication, its half-life is 11 hours. But if it is an injectable medication like Endurimab or Galcanezumab, it is about 5 months of washout period is needed before you clear the medication from the system. So especially if it is a woman and she wants to conceive, if the patient takes monoclonal antibodies, she has to wait for at least 5 months after the last dose of injection to become pregnant, as the washout period is 5 months. However, if the patient is taking oral medication Ramjepan, the washout period is around 5 days. So this is one of the important advantage. Some patients don't like injections. They are willing to take oral medication. So this will be advantage. There is no contraindication. For example, patients who are taking Endurimab can't be used in patients who are having increased cardiovascular risk factor, especially hypertension and constipation. As I told you, there is no evidence of wearing off. We have seen patients who are receiving monoclonal antibodies. The last 1 week of medication, patient can have rebound headache. However, as patient is taking every other day, the chance of wearing off is very less in patient on oral medication. When a patient was used Ramjepan medication for acute therapy, they also found out if the patient is going on using 4 or 5 times medication per month, their migraine frequency also reduced when this was used only for acute therapy. So this was an extended trial which found out there is significant reduction in monthly migraine headache when patient was using medication when needed. Ramjepan is well tolerated for both acute and preventive treatment. The percentage of patient with nausea in acute and preventative is around 2% compared to the placebo, and abdominal pain and dyspepsia in patient who is having preventive therapy. Across acute and preventive trials, discontinuation rate due to the adverse effect was less than 2.7%, which is comparable with placebo. So here we have a medication. It is a Ramjepan, which is used to treat acute therapy and preventive therapy. There is no medication at present available which can be used both treating and preventing. This medicine is used as a 75 milligram oral dispersible tablet whenever needed for the acute attack. However, you can take only one tablet in 24 hours. In preventive therapy, it is every other day the patient should take medication. What are the important safety information? It is contraindications are hypersensitive to medication or any component of the medication. And adverse effect, as I've already mentioned, nausea, dyspepsia, abdominal pain. One caution with this medication, when we use this medicine with inhibitors of CYP3A4. So there is this Remdesivir uses CYP3A4 as an enzyme. If this enzyme is inhibited, the concentration of Remdesivir increases in the blood. So it stays in the blood for a longer time. So if we are using a medication with our inhibitors of CYP3A4, we should not take the medication every 24 hours. Instead of that, we should take once in 48 hours. And if we are using medication which are strong or moderate inducer, the medication level in the blood is less. So we might have to use this medication more frequently, maybe 12 hours. However, there is no study which is available regarding use as for the inducers. I like to tell you one more important point. This medicine is not studied in pregnant women and breastfeeding, and hepatic impairment, avoid use of Remdesivir in person with severe hepatic impairment and end-stage renal disease. What are the most the medication who are inhibitors, which will increase the Remdesivir or clarithromycin, and medication which are used for HIV infection, and verapamil, ketoconazole, itraconazole, and inducers are carbamazepine and phenytoin, where you might have to increase the duration or frequency of medication. I like to thank all the listeners for attending, and I'll be happy to answer the question if.
Thank you, Dr. Al-Present, about this interesting presentation, especially about rimegepant and the management of migraine with the new medication. Your first question from the audience that is reaching for tonight more than, we are around 1,600 audience. So thank you for our audience. Thank you for our sponsor, Pfizer. Thank you for Migraine Masterclass and for all the collaborative companies. So your question for tonight, the first question about diet, is chocolate, soft drinks, or vitamin D has any effect on migraine?
Yeah, so see, there are few patients, as we have already discussed in the previous session, chocolates, especially the dark chocolate, can trigger. There are patients who can diet can trigger, which is individualized. It is not like normal. For example, cheese, bakery items, the content where MCG is present can trigger the headache. So what I usually tell the patient is to maintain a headache diary, where patient, whenever they have a headache, they will write it down what they have done 24 hours. It is external and internal. External is change in the weather, loud sound, and taking food, specific food. Some food items can trigger. So it is very difficult sometimes to notice, but when they maintain a diary and find out those triggers, and they can find out these are the possible triggers. Coffee can be a trigger also and can be a treatment. Some patients drink coffee and they develop more headache, and some patients get relieved of coffee. So food wise, some of the foods which you don't even think, like previous speaker was telling, the pizza was not triggering, but particular pizza from particular place was triggering. So some food items also can trigger like that. So it is individualized. There is an application which I think I will always tell the patients to use, called Migraine Buddy. So this is an application which will guide the patient what could be the trigger, because patient can monitor.
Thank you for your answer, Dr. Al-Present. The next question related to your topic, do you give combination injection anti-CGRP monoclonal antibodies and rimegepant and gepant in general?
Yeah. So we don't give two preventative therapies. That means we don't give monoclonal antibody plus Remgipan every other day. However, we give monoclonal antibody plus whenever needed Remgipan. That is for acute treatment. So we don't give two CGRPs together because we have no study which has proven that it is beneficial over a single CGRP medication. So we use for one medication for prevention, other medicine is only for acute treatment.
Thank you for this answer. And the next question is, I don't know exactly, but immune affection and price, please. So I can help you for the price. The price in UAE of Rimegapant, which is like 8 tabs, is around 1,300 dirham.
Yeah.
It depends on each country. And immune affection, so
I also was not able to get that question.
maybe I can ask it in different way. Any antibodies against gepant in the blood after taking like the medication for certain time? Do you have any experience in that?
So we don't have any data which showed that there is an antibody against Ramgepant, because Ramgepant is a small molecule. It is not an antibody. It is a small molecule against. It is like any other antagonist medication. So we don't have any data, the antibody against this particular medication.
The next question, interesting question. Any indication of Rimegapant in cluster headache?
Yeah, it is a nice question because we know that CGRP is one of the important trigger. However, there is no studies which have come and proven to be beneficial. However, we have a medication called galcanezumab. At 300 milligram of galcanezumab, it is very useful for patient in cluster headache.
So maybe let's wait future studies about the other entities.
Yes.
For my information, the anti-CGRP also was tested in trigeminal neuralgia, but it didn't give exactly very good results. So still till now, it's more indicated mainly in migraine. Dr. Halprasant, any studies of Rimegapant in children?
I think there is a study which is ongoing right now in children and Remgepant. I am not aware of any early results, but I think there is a phase 3 trial which is going on. I think it will be, as a previous speaker was telling, there will be definitely change in the treatment in another couple of years, especially in children. Usually, this is how the evolution of medicine happens. We usually we don't want to have any complications, especially when we start a new drug. So 18 years and above was the study. All the study were more than 18 years. So once there is a safety data in adult, I think it will move on to pediatrics, probably in pregnancy later. So we are in the stage 2 now.
Thank you for this answer. And another other question about maybe the interaction of Rimegapant with other medication. As the person is asking about ketoconazole and the interaction with Rimegapant.
Ketoconazole is an CYP3 inhibitor, so it increases the dose of Ramgepant. So Gepant's doses are increased. So we should not give for acute therapy. We should give once in 48 hours rather than 24 hours. And preventive also, we should give once in 48 hours rather than once in probably 96 hours rather than 48 hours, because there is an increased delay in the metabolism. So there is more medication in the system.
Thank you. And Dr. Muhammad is a psychiatrist. He's asking if it can be prescribed with low dose of lamotrigine, 50 milligram.
Yeah, so we do this type of treatment where patients who are already on I'm talking about migraine, anti-epileptic medication. For example, topiramate was used, and we can add medication, which is Ramgepant or monoclonal antibodies. But usually we don't use lamotrigine in migraine. I don't think there is, if the lamotrigine is used for any other condition from psychiatrist. there is no problem in adding Ramgepant for migraine.
Perfect. So I will go for another question related to our topic tonight. In the preventive treatment, how long would the patient be on the medication for preventive treatment, and what criteria is used to stop preventive treatment?
I think it's a very interesting question. I think this is a very debatable and challenging question.
Yes.
As we know, the migraine is a chronic neurological disorder. So this is a chronic. So we don't know how long the medication to be treated. However, the new guidelines say we should treat the patient as long as patient has headache. So initially, we always used to say the patient is having a migraine headache and we'll give for 6 months to 12 months medication. We found out that the patient whom we treat for 12 months, after that we'll give a gap and we'll see if the patient is having a recurrence of headache. There is 20 to 30% of the patients will not have recurrence of headache or very less frequency. So we can use only acute therapy. For patients who has a rebound headache or a headache which comes back after stopping after 1 year, we reintroduce the medication and we don't stop the medication. Probably we use as long as possible. The new data which came up from the European guidelines, so they use this word, as long as patient has headache, we should use this medication. I know it is very expensive. And I usually do in my clinical practice, I give for 1 year, I'll give a break and see how patient responds.
Yes, exactly. So, and one of our audience is asking you, should we try ditans? It means maybe lasmiditan, what he means first before jumping into gepants. Any specific indications for ditans, lasmiditan?
See, as we know that ditans and gepants are a third-line medication in acute treatments. So there is no harm in treating with ditans first, then the gepants. So if the patient is able to take the medication and tolerate. So mostly whenever I have used the lasmiditan, I had a problem with medication. Some of the patients comes back and tell I feel very drowsy. And usually they want to drive, and there is a caution that they should not drive after taking this medication. So the patient who are going back home and sleeping and not driving, this medication is effective. So other than that, if the patient is tolerating well and patient is not having any side effect, we can use ditans before using gepants.
Thank you, Dr. Halprasan. The next question is, maybe it's an interesting, also challenging question, is about the patient in the first trimester of pregnancy. What is the drug of choice if she's suffering from migraine?
I think till now, we don't have any medication which is approved in pregnancy. Usually what we do for prevention of migraine, we usually use not a usual first line, second line, third line drug. We usually tell the patient that avoid triggers. I use magnesium. So I use magnesium and I use paracetamol whenever needed. However, in a patient who is having a severe migraine headache, there are 2-3 options which we can use. There are some devices which are available. We don't know how, there are trials which have found out that these are efficacious, but we don't know in pregnancy, is it really any study has been done that can be used. Sometimes very severe headache, we can even use occipital nerve blocks, which can be used. Or another simple thing which we can use is spinopalatal ganglion block, which is actually lidocaine. We dip it in the cotton and just put it through the nose. So it is a local block, which might work. The side effects are very. These are all the medications which can be used, but we usually convince the patient and tell that there is a side effect of the medication. We don't know, especially in first trimester. So we always tell the patients that it is better that we don't start any preventive therapy, and we use alternative treatment like magnesium.
Thank you for your answer, Dr. Halprasan. I think one of our audience is asking what kind of magnesium used in pregnancy. I think most of the magnesium. What's your experience? And magnesium?
We have magnesium. This is magnesium sulfate. It comes as normal magnesium with 400 to 800 milligram per day. So
Yes.
this is the medication and dose we use. So recommended dose is around approximately 10 milligram per kg. So we should actually use minimum 400 to 800. So
Yes.
if you're using very low dose, there is not much useful.
So 400 to 800 as maintenance dose. Okay, so the other question is, we don't use acid. I think that it's not, maybe they ask about which one do you prefer, acetaminophen or Migraine, maybe. This is what I'm understanding from the question. It's
Yeah,
not-
how to choose medication is individualized. I see patients who are doing very well with paracetamol. For those patients, there is no need to change to another medication because they are doing well. If the paracetamol is failed, we can use other non-steroidal anti-inflammatory drug like naproxen, brufen, or diclofenac sodium medication. Especially a powder of diclofenac works very faster. However, they should not use this medication more than 15 days in a month because it can cause medication overuse headache. If they don't do well with this, we can shift them to triptans, so which can be sumatriptan or rizatriptan or zolmitriptan. That is how is the second line drug. Sometimes I usually combine triptan with non-steroidal anti-inflammatory drug, especially naproxen. They have a very good efficacy and good response. If they don't respond well, then we have to go with GPANs and DITANs.
Thank you so much, Dr. Halprasant, for tonight, for this excellent presentation.
Thank you so much for the opportunity, and there is a very good audience, and we are very happy to be here and answering all these very nice questions.
Thank you so much for our both speaker, Dr. Diana Dugan and Dr. Halprasant DS. And I will leave the floor to Ms. Maya to give you our next event. So thank you so much for tonight.
Thank you so much.
So, thank you. Let me first thank Dr. Rodi Nawar, our also specialist neurologist, also expert in the field of migraine. So thank you for this excellent moderation and for taking care all of the questions and trying to answer all our audience questions. Also, let me thank our almost 1,600 attendees who joined us despite that we are in July in the middle of the summer vacation, but we are also proud to have you all, and thank you for all of you for attending tonight and for staying with us until the end. Also, I would like to thank our excellent speaker, Dr. Halprasant and Dr. Diana, who joined us from the UAE and from USA. Also, the big thank you goes for our collaborator, the Association of Migraine Disorder, who planned and with us this session, and for our sponsor, Pfizer, for supporting us. Without your support, we could have not done all the success. I would like to remind our audience that you will receive your certificate of attendance by email within 1 week of tonight, and this webinar is CME accredited, and you will receive 2 hours of CME. Also, if you missed any part of the sessions, or you would like to revisit the presentation, because I received a lot of questions about having the presentations or if you can have the recordings. So actually you can have access to the recordings and the presentation by visiting our IVPN library online, and the IVPN library content is currently available free of charge for you, so you can go and visit and revisit all the lectures. Also, a final reminder to follow us on our social media platform by liking and following our LinkedIn page, where we post all updates in the neuropsychiatry field and where we announce all our events. Stay tuned for our 8th migraine masterclass that will take place in end of August. So keep your eyes on our social media platforms, and all the details about registration, the agenda, and the exact date will be posted very soon. And until I meet you again, have a good night, everybody. Thank you.
Thank you.